I want to start with the first statement. I think it would be the best option if I asked Theo Koster as a patient speaker to address that statement, to comment on that statement. Hospitals should be responsible for supporting systems to create IPUs. Theo, are you somewhere around in the cloud?
I am.
Ah, hi Theo, nice to see you. Well, I don't see you, but I can hear you. Can you comment on...
Well, that should surface.
Okay.
Well,
go ahead. The floor is yours.
From a patient perspective, it's difficult to say so. I guess it would be best if it came from bottom up, if it would be carried by professionals. But I think for a professional, it would be quite difficult to establish an IPU if he were to build it against all odds and against all budgets and all managerial requirements. If you take the value of an integrated patient unit, that's quite high from a patient perspective, because if you are a patient, well, a few of them can be qualified as quite assertive and actively involved in their own route through the system. But anything that eases the experience for the majority of patients would be very valuable. Right. Being a patient is a quite bewildering experience for the first time. I mean, your body is failing on you.
That's a great statement, by the way, Theo. Yeah. Great statement. Being a patient is bewildering. Oh, you're...
That's true.
Yeah, okay.
I can speak from experience, and
you're
sent on your own quest through the hallways of these large buildings, meeting all kinds of clinicians who will ask you very personal questions and poke into your body. You're subjected to machines. And all of it is, I mean, it serves a purpose, but it's not really something you wish upon yourself. So anything that will help a patient to take care at least of the logistical part and the speed of it would be really valuable. Great. That's one thing that's for sure.
Okay, thanks. Arie, Franx, are you somewhere online?
Yes, I am.
Ah, great. Hi. Good to see you.
I can see and hear all of you.
Oh, great. Can you comment on the first statement?
Yes. Yes, I heard the plea by Christina for resilience of the healthcare system. And if we want to deliver personalized care, so care tailored to the needs of the individual patient and what matters most to the individual patient, the consequence of that is that hospitals should turn into a flexible system, because the care path and the IPU would not only differ across patient groups, but even across individual patients within a group. And that would be the ideal world, in my opinion. On the other hand, that is a huge challenge to organize, because now hospitals still think in departments. So the move to the organization of multidisciplinary care is only beginning.
Can I ask, Gabrielle, you're used to work with multidisciplinary teams, of course, as a radiation oncologist. Do you think that flexibility, which is proclaimed by Arie, is feasible?
Well, I agree in a part, because I noticed that we are so little looking on the outside, looking in. We're building on so many assumptions, and it's striking, for me at least, that we are asking the patient so few for the feedback, experience, or perception. So what Theo brought up, like it would be helpful if the logistics at least would be managed. That's something I experience as well in my clinical setting. So, well, this is really confronting. We have to just keep this in mind, that this is at least something we should have been managing all the time. So that we are really speaking with the patients, that's the other part. We are really, what's really driving him or her? That's something that's the most important in my work. So for me, it's a no-brainer.
Yeah, so you should emphasize much more the patient-reported experience measures. Yes, thank you. Arie, I can see you.
Yeah, hearing this, I have another reflection.
Go ahead.
I'm quite far in my career. I'm almost 60. And when I look back 30 years, things were different. And one asks himself all the times, why have things become so complex? So we explained it by increasing comorbidity, etc. But that is not entirely true, because in the past, patients who came for a gynecologic operation also had diabetes, and also had clotting problems or anticoagulant treatment. I think that it has also grown complex as a consequence of the advancing subspecialization. So you get more and more professionals that only know everything of a very small part, sometimes even one disease. So now, when I was a resident and there was a diabetic patient with anticoagulants, we prescribed her drugs ourselves, and we were trained to do so. And now we call the other discipline. So we have complicated things also by focusing on a particular small part of medicine, all of us, in the past decades. So another solution is to reverse that maybe a little again. Now I
Okay,
need
thank you so much. I think Gabrielle wants to
one
add
patient, and in the past I did all myself. I exaggerate it now, but,
Yeah.
to challenge you a little bit.
I think Gabrielle wants to comment on that.
Yes, I completely agree on that. I wrote a blog many months ago about this issue, and well, I'm not the only one, because there was someone before me and he suggested to have more general doctors. But I think there is a solution to that. As we have all the technology in there, it's waiting for us to be implemented. It's only a matter of orchestrating the data and the technology in the right way together. And it's just a matter of mindset and collaboration to do that on a completely new way. And I say this because we are now just throwing all together, if it's standards or it's technology or it's data, and we all mix it up. But we should just keep in mind that it's just a connection between me and the patient that is really confidential, and that's something we should manage in using our technology to be connected. We need this trust relationship, because this relation is built upon trust. So no data, FHIR-enabled APIs, throwing them to third parties with a license agreement that no one ever will read. And if you are ill, you won't manage to read all these license agreements. So we really need someone that's doing the data curation. And I think this is the normal thing, to just translate our Hippocratic Oath to new technology coming in, and to do this data curation on behalf of the patient and with the patient. Okay. So this is some part, and there are more parts to it, but we can manage. I think the solution is there.
Okay, so that's very nice to hear. Maybe that makes a little link to the next statement we want to discuss. Is new technology will only work if the industry is also part of the compensation. Maybe, I don't know who of you three wants to comment on that.
I always want.
Ah, you always want to comment. Did you say you always want to comment, or you want to comment?
The first.
The first, go ahead, Arie.
No, that's a joke. Yeah, I think that everybody knows that in this country the current compensation system is DRCs, and that is just fee for service in a modern form. And I experience this as an enormous obstacle to innovation in general, but in particular to implementation of technological solutions. And if you want to negotiate a reimbursement for new treatment or technology, you need an RCT to prove that it's better than what exists. The RCT, in my opinion, is an outdated research model because it cannot keep up with the speed of innovation at all. So that is a problem. So yes, if this new technology adds value for the patient, it should be included. And I think that one of the solutions would be, and Christina also made a plea for that, is outcome-based reimbursements, which is a long road here in this country, unless the technology is so good that it can increase efficiency right away and can become a part of the DRC instead of other things we do. And a good example of that, we have seen that in the COVID crisis, wave 1, like telemonitoring. We can do it technically already for years, and nobody implemented it, and now it's all over the place.
Yeah. Theo, I saw you wanted to comment on that.
It's a more maybe generic comment, but from a patient's perspective, which is my perspective, I'm not looking into compensation or anything, but the distinction between a technology provider and a physician is wafer thin, because the treatment is prescribed by the physician. So the brand of medicine or the machine or the scanner I'm in is also directly connected to this care provider. So I, as a person and as a patient, I don't really mind if there is a close connection between suppliers and appliers and the whole. I mean, to me, it's just one big thing. And I know it's a huge thing within hospitals, but for a patient, I mean, my medicine are prescribed by my physician. So by definition, it's the brand of medicine is closely connected to my physician. It's one thing. So don't be too afraid to cooperate with, or at least cooperate actively with providers, because by a patient you will be automatically connected as one big thing.
Gabriella, what's your comment on that? Because you're a specialist, at least what I consider as a specialist in AI solutions.
Well, I'm a specialist in being a doctor. That's the first part.
That's
I
the right answer. Yeah.
Really enthusiastic about what's possible to restore the tasks that I'm performing and making workarounds every day. And all of us is making all these workarounds around technology that's not truly, well, how to, you know what I want to say. So the true connection is the open and the warm and trust relation that we should have central in this discussion. And then that's something that I'm asking my patients every visit, not the tumor, the medical part, but the issues that they present with. And most recently, I've started further research in this domain to study the experience of a patient with a doctor, but as well vice versa, because that's also very important. And I think this is the heart of care. And from that point, we can derive all the things. But we started first with the technology coming in. So now we have to go back to our basics and say what's needed to really be digital, because we became digitized. And we have to step back, I think. Yeah. And then that's something that Arie will agree on, because then we can be the doctor that Arie was, and we can be a more powerful doctor because we get more insights, more wisdom because of this technology.
So with the technology, we should go back to the connection between doctor and patient and be an equal level connection instead of the patriarch situation we had a generation ago. Okay, thanks so much.
Gabrielle thinks according a 2,000-year-old principle, and that is the Hippocratic Oath. And I particularly like that you refer to that, doing the best for your patient. And that's nothing new. And the systems we've put up, the barriers we've put up are in the way, and we should we should clear them away, I think.
Well, thanks for that last addition. It's also a sort of a stimulation to go back to the Greeks to listen what they said 2,000 years ago, or more than 2,000 years.
Nothing new under the sun.
Exactly. Meanwhile, there's something new under the sun, at least we think it's new. It's the COVID epidemic. There was one statement, is value-based healthcare can help us during this COVID epidemic. That's of course a challenging statement, but who wants to comment on that?
Perhaps Theo is the first.
Theo, can I give you the floor? It's probably because Arie just wanted to think a little bit about it.
Buying himself time.
Go ahead.
No, I honestly, I've been in intensive care. The best advice I can give about intensive care is stay the fuck away. it's really a horrifying experience being on the receiving end of intensive care. But no, I don't know. I really don't know. I can't really comment on it. I've seen or read about the overflow of patients into intensive care, and I hope value-based healthcare somehow did contribute something to it, but results showed that we were couldn't really cope with it. But from a patient perspective, I have no valid opinion on this. I'm sorry.
Arie, Gabrielle? Yeah, I would like to say something. On the one hand, that would be ideal, isn't it? That value-based healthcare principles would help to triage who is going to the ICU or not, be it COVID-19 patients or be it non-COVID-19 patients requiring ICU. But on the other hand, you would require some knowledge about the outcome. And as I understand it, we don't know very much still on the long-term outcome of passing through the ICU because of COVID. And that would interest me personally if I was the one to go to the ICU or not. I would ask if I still could at the moment, how will I come out?
Yeah. Maybe we should focus the discussion. I'm also on the supervisory board of a nursing home organization, and I think that the principles of value-based healthcare is very relevant there. It's what matters to you. What do you want to have? And I can imagine some elderly people say, okay, there's an increased risk of getting COVID and dying from it or getting severely ill. But I prefer that risk than the joy of seeing my family or friends, etc. Maybe that's also a principle you could address. So somewhere it's already there.
And also for other departments than the ICU, we know the example Willem Jan Bos showed, that if you have a good discussion with the elderly with terminal renal insufficiency, quite a few of them will choose not to have dialysis because they spend the rest of their lives on the machine rather than with their families. So I would say for things we do know, we possibly can have a better, more complete and open discussion with patients who can go to who can come to the point of going not to the ICU. But for particular COVID patients, that is not that easy because we know very, very little about their outcome as yet.
Okay. Maybe I could go to the next statement, or actually skip the fourth statement and go to the fifth statement. And I know we are more the technical part or the curative part of doctors here, and Theo is, of course, not a doctor, but I still want to discuss the statement to reduce cost. Value-based healthcare should focus more on mental health than purely somatic health. Where we don't have psychiatrists or well-being specialists here around, but did you dare to comment on this statement?
We should all become a little more psychiatrists and internal medicine specialists than we are. My answer to this one is without any doubt, yes, with an exclamation mark. We have used the pregnancy and childbirth outcome set in our department. We just retrospectively sent it to all the patients who delivered here in 2018 and 2019. And guess what? We saw that quite a few of them had alarmingly many symptoms of depression, and we were shocked to see that. We just don't know. So yes, there should be a stronger focus of our attention for all patients, their mental well-being. So I agree with Christina that there's a lot of suffering and costs involved with that, and requires our attention.
Theo or Gabrielle, do you want to comment on that statement?
Well, I agree on that, and psychiatrists will be the first to adopt these new studies that Arie earlier talked about, because randomized controlled trials will be more of a data-driven thing in the near future, I suppose, or they are already, because we don't know for sure if the diseases fit into the symptoms, etc. So for me, I don't see a difference between the mental part of a person and the tumor and the toe or the nose or the ear. So that's the full human coming in, and I have to not take care for all these things, but I have to keep them in mind. And sometimes I will do something on something that's not completely the tumor, but something to make the patient a little bit more comfortable on the mental part. And that's, I believe that's so important, because otherwise I'm just really, well, a robot can come in and do the radiation treatment for me.
Well, thank God we're not robot yet. Theo, and then Theo, can I give you the floor? You had something.
Well, from my personal experience, the best physicians I experienced were generally quite old, on the older side, and they were able to actually match their technical knowledge, for instance, internal medicine, with judging how well can a patient really accept this treatment, especially on chemotherapy, and is it still necessary for this patient? Not only looking into blood values or whatever methods they use or scans, but also looking to the patient as a human and looking to their family. That's another, can the family still support the patient?
No.
And I experienced some elder physicians, some elder doctors and nurse practitioners who actually treated my wife next to me as one unit, which was a really interesting experience. I called it, this was quite holistic medicine.
Okay.
I think, specialists.
Yeah, maybe I should summarize it, that we should probably pivot from the technical outcomes to more the mental and social well-being of their patients and their surrounding and the loved ones.
Going back from the science of healthcare back into the art of healthcare.
That's a great way of saying it. Thanks, Theo. What we are going to do, we've got some technical problems with the server, so the breakout rooms are difficult to reach. So what we are going to do now, we'll have a 10-minute break till 15:15, and then we'll try to restart the breakout rooms, and otherwise we have a plan B, how to listen to the nominees. But for now, we have a break until 15:15, so grab a drink, grab something to eat if you want to, say hello to your kids or wife or colleagues,